Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and this podcast exists so that you can learn about your health, hormones, and your fertility. Today, we are talking all about how to improve cycle outcomes. So whether you're doing egg freezing, IUI, or IVF, sometimes the cycle doesn't go exactly the way you want it to. We know how disappointing that is, but the reality is fertility care should be personalized. And sometimes we choose the absolute best protocol we can, and your body doesn't like it. It's not the right one for you. Or we learn about you, or we learn about your infertility as you go through the process. So today I'm answering some listener questions about their protocol or suggestions in general that maybe we can think about if we are trying to improve our own outcomes going through fertility treatments. Before we jump in, a few things. Thank you guys so much for all your love and support. The YouTube channel is growing as well, and if you want some more content, you can check out Natalie Crawford MD over on YouTube, short videos around 10 minutes in length answering some of your top fertility questions. You're also going to hear some of your own user questions in this episode, and if you want to call and ask your own question, you can call 657-229-3672. Again, that is 657-229-3672 to leave your question on the As a Woman voicemail. We also answer questions over on Instagram every Monday at Natalie Crawford MD. Some of those questions are answered right on Instagram, here on the podcast, or on the weekly newsletter. The weekly newsletter has updates, my favorite products, fertility-friendly recipes, and then some of your fertility questions answered right there. Not spam, but a little piece of education that you can take away each week as you are working on learning more about your own body. So you can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And we haven't talked about it in a while, but if you go to the website, you will find a resources tab. This resources tab has all of the YouTube videos, blogs, podcasts that we have in our content library, and you can search any topic. So maybe you want to learn more about egg freezing, feel free to type in egg freezing into the search bar, and you are going to see all of the content that has been made talking about egg freezing right there for you. So if you are really looking for one specific thing, that is a great way to go get a little bit more information as you're working on educating yourself and learning more about your body so that you can be a better advocate on your own health journey. With that, we're going to dive in and talk a little bit about cycle outcomes and what you can do to improve them. Starting first with a listener question.
Hi, Dr. Crawford. Thank you so much for everything that you do. I'm so grateful for all the information that you share. I have a question regarding multiple egg freezing cycles. I just completed one egg freezing cycle last month, and I'm going to wait a couple of months until I try to do another cycle during the summertime. I'm a freelance dancer and choreographer, and so I'm just trying to get some work before I do another cycle. My AMH is quite low, 0.7, I think was the last number that I got, and my antral follicle count from my last egg retrieval was 9. We were able to retrieve 9 eggs, actually. 6 were M2 maturity, 3 were M1 maturity, and they ended up freezing all of them. I am curious to know if you have any suggestions on how I can improve my outcome the next cycle that I do, and if there's anything you feel like I should avoid for the next couple of months, things that I should continue doing for the next couple of months. Because I have such a low antral follicle count, I'm hoping to do just the 2 cycles, but if I have to and feel like it would be worth it to increase the number of eggs that I do retrieve, I will do a 3rd one. Just curious to know if you have any thoughts about that and if you have any suggestions. Thank you so much, and I hope to hear from you.
Okay, this is a wonderful question. And when we are going through any type of cycle, whether it's egg freezing or IVF, one of the things that we are looking for when it comes to is the protocol doing its job is how many mature eggs did we get? If we think about what's happening in these treatment cycles or in any cycle in general, let's walk back to the analogy that you have all the eggs you're ever born with, and I like to think about them as being kept in a vault inside your ovary. Every month you have a group of these eggs coming out of the vault. Each egg is small, microscopic, and it grows inside a small fluid-filled structure called a follicle. Now the brain will send out follicle-stimulating hormone, or FSH, which is well named, to get one follicle to grow. And as that follicle grows, the egg is going to mature, and then eventually that will ovulate. The rest of the eggs that did not grow or ovulate that month will die. So you're always losing more eggs than you're ovulating. You'll get another group of eggs coming out of the vault, and the process will happen over and over again. When it comes to doing a cycle, we can only get the eggs that are outside the vault to grow. This is an important concept because I can't tap into the vault, which is good. You're not going to run out of eggs any faster, but it's also bad because if you have what's known as low ovarian reserve or a lower egg count, I'm not able to get as many eggs as I may be able to get from your best friend or from somebody you know, despite you being the same age. Because what happens is that everybody has a lowering of their egg count over time, but some people are born with a lower egg count or they run out at a faster rate. There's some variables which can influence the rate of decline of your eggs. And I like to imagine there's this vault keeper in that vault who is deciding which eggs are going to be sent out that month. So when you have more eggs, imagine a really crowded vault, a very crowded room. The vault keeper doesn't want to be crowded, and so they're going to send out more eggs in those scenarios. So somebody who has a high ovarian reserve or a lot of eggs left will have more eggs available in a given month than somebody with a low ovarian reserve who might have fewer eggs remaining. They are going to be on a pathway to be running out of eggs faster, and they will be able to get less eggs per cycle of IVF. So when somebody talks about a cycle or a round, we're really talking about that month's group of eggs. And even if you are preventing ovulation, maybe you're on birth control, maybe you can't ovulate because you have PCOS or hypothalamic amenorrhea, maybe you're pregnant, you're still running out of eggs all of those months. Just nothing is ovulating. So this idea that we can change this rate of decline is really not true, and that's an important thing for us to realize. We can measure your ovarian reserve by checking a follicle count. So our listener here said her follicle count was 9 before the cycle started. So that means somebody did an ultrasound and counted 9 follicles. You can also test a blood test called AMH, or anti-Mullerian hormone. And AMH is going to be a hormone that is made from the cells that surround each follicle. So more eggs in the vault, more come out every month. Higher AMH, then fewer eggs in the vault, fewer come out, and a lower AMH. An average AMH is going to vary based on your age, just like an average follicle count will vary based on your age. An average 30-year-old might have a follicle count of 16 to 20 and an AMH of 2 to 4. An average 35-year-old might have a follicle count of 14 to 15 and might have an AMH of 1.5 to 3. An average 40-year-old might have a follicle count of 8 to 10 and have an AMH of about 1. So you can see that these numbers differ based on averages and age and what you should have. So having a low follicle count or low ovarian reserve means that we have fewer eggs as an opportunity to grow that month, and that does change the protocol or what we do to get the eggs to grow. The protocol in IVF is the combination of medications that are overriding the normal brain-ovary communication. If we remember that the brain talks to the ovary responds, they are best friends who only want you to carry one baby at a time. So they are made to not let you ovulate 10 eggs a month, because if you're ovulating 10 eggs, you have the potential to get pregnant with 10 babies at one time, and that is not how the human body is made. So the brain and ovary are made to prevent this from happening. But if you're doing egg freezing, I would really like all 10 eggs that are there to grow. So I want to break up the brain-ovary communication and then override this system in order to get the job done. And this is really what your REI can do, number one. What we can do is try to pick the combination of medications that is going to do this in the best way, hopefully get you the highest number of mature eggs and the best quality eggs. The protocol is a combination of suppression and stimulation. We have to suppress your body so you do not ovulate, and we have to stimulate, get the eggs to grow. I like to use the very bad analogy of imagining a nest of baby birds, and mommy bird is bringing in a worm, and the biggest bird gets the worm, and that is normal ovulation. So I have a nest of birds, biggest bird gets the worm is FSH, the hormone coming from the brain. What I am trying to do is make sure there's no big bird. So if I starve all of the eggs at first, they're all really hungry. Then I have this nest of little birds who are very hungry with their beaks open, really waiting for that worm to come in. And if instead of having just one worm, I now dump a bucket of worms in that nest every day, now my birds are going to gobble up these worms at the same pace. They are going to eat and grow together, and hopefully all get to that mature size at the same time. And that's the idea here of what might happen in nature. And what we're trying to have happen in our IVF or our egg freezing cycles is override that natural process. The truth is the stimulation is pretty similar. We need FSH, and you need more FSH than the brain is normally going to make. The core medication with the stimulation is FSH, just injectable FSH. Synthetic compound, exactly the structure your body makes. Much higher doses than your brain would ever let you have. Sometimes there's some additional medications. So one is an FSH-LH combination. Very interesting. So we actually can't synthetically make LH really well yet. And so you don't have an isolated LH compound. We use a compound that is a combo LH-FSH, and it comes from the urine of menopausal women called minotropins or menopure. What happens is that when you're in menopause, your ovaries are now out of eggs. The brain really, really would like you to ovulate, and it is sending out all of the FSH, all of the LH it has, trying to get the ovaries to do something. So your normal levels of FSH and LH, which when you're ovulating, you're not in menopause, those levels are usually about 5 to 10. In menopause, those numbers are over 40, and most of the time they're closer to 80 to 100. The brain is working so hard. So you can take the urine of menopausal women that's high in FSH and LH and purify it, and then use that as part of your LH. And some people need LH because they don't make any, or because of the protocol you're using. So long-winded to say, I think that's just fascinating. But there's an FSH, which is the core of a lot of our hormones, an FSH-LH combination that is very often used. And then sometimes there's medications to try to get your brain to release some FSH that might be there. Medication like Clomid is a good example. The suppression is what you have a lot more of an opportunity to use. You can use ovulation blockers. You can use a medication called Lupron, which binds at the brain. You can use progesterone. And there's these medications essentially that are modulating your hormones. Sometimes we like to start the suppression before the cycle even begins. And I honestly think this is an important piece for most patients, because you're really laying the groundwork that there's not going to be a quote unquote big bird. Because if I prevent anybody from ovulating, everything is small. So an example of I can use the birth control pill, and now there is no big bird, everything's nice and small, then I can come in and use my FSH and get the eggs to grow because they were starved, and now they're very hungry, and now I'm giving more FSH than your body would want. When we look at a protocol, the goal is to try to get as many mature eggs as possible, but we're limited by our own potential. This is one thing where I think it's important to realize a lot of clinics don't personalize protocols. They do the same protocol for every patient. It is easier. It's easier for their staff to protocol it, to do the same thing, and they don't modify it if you don't have the outcome that you want. And that's really sad, and that is part of why you've got to understand this if you're going through the process, if you want to try to maximize your outcome. I always say your first protocol, we are doing our best and making our best guess. That is so true, even if I'm using all the knowledge I have. But your second protocol, I should be able to be making some change to try to make it better, whether I'm switching the whole protocol up or I'm just slightly switching the size of maturity I need or the length of the trigger time, or I'm adding some human growth hormone or doing something. Unless you had a perfect outcome, what can we do to be better is always a good question. And maybe the answer is, hey, you did great. That's exactly what we expected. Do it again. But you've got to be asking the question. Common things that I like to think about here is, why is our AMH low, especially if that's low for your age? Top causes can include something like an autoimmune disease, an inflammatory disorder, endometriosis. Those things might benefit from cycle protocols that include Lupron, Medication that blocks at the brain level to prevent FSH and LH from being released also suppresses endometriosis and inflammation and can be advantageous for people in that scenario. I don't love an antagonist protocol or an ovulation blocker as a first line for some of these women who have a low egg count, especially if you are young. But there's many different options. So what was your protocol? What were the medications used? Are there other options to consider? So that is thought number one. Thought number two is the dose of the medications. Very often there are max doses that you don't really go over. Usually that's about 450 total of gonadotropins, however you split it up between FSH and LH. And if you're on max dose, there is no evidence that doing lower dose is advantageous. It's more of a threshold response. So if you don't need high dose, why spend the money and use high dose? On the other end, you can absolutely understimulate somebody. And we sometimes do that on purpose. If you have 82 eggs, I don't need 82 eggs. So I don't want every single egg to grow. And by using less gonadotropin, that can be a strategy to do IVF in a safe way. But what were the dose of medications, the ratio of FSH to LH? Did you have any LH on board? Should that be added if you did not? Omnitrope or human growth hormone is something you can consider adding on in very same cycle where the protocol wasn't changed at all. The months were back to back. The addition of Omnitrope improved the maturity of the eggs and the number of blastocysts that you made if you were going through IVF. So this is something that I don't throw on to everybody. It's not FDA approved for this indication and it's expensive. But especially if we maybe did less than I was hoping, or I'm concerned about the number of eggs you might get, this might be an opportunity to try to see if you can make a difference. And then we're really looking at some of the cycle-specific and the trigger-specific parameters. So the length of the trigger interval is very important in the maturity of the eggs. And this is a crazy thing to me. Every clinic is a little bit different. Typically, there is somewhere between a 35 to 36-hour trigger, meaning you take a shot to help your eggs finalize their maturity. And this means they're going to resume meiosis. When I think about the maturity of an egg, I want you to think about a GV or a germinal vesicle nowhere close to mature. And M1 has completed the first stage of meiosis, close to mature, but not there. And M2 has completed the second stage of meiosis. This is the golden ticket. This is what we want. M2s can be fertilized. M2s are what we quote unquote say mature. And then past that, you can have eggs that degenerate or that are post-mature. And so we're really trying to shoot for these M2s. M1s were really close. So when I'm looking at the maturity scale and I see a third of my eggs as an M1, I would say, okay, maybe I can lengthen that trigger interval. If I got all the eggs I was following, some of them just need to get more mature. Maybe instead of a 35.5-hour trigger, I'm going to lengthen it and do 36 hours. Sometimes I'm going to say, especially if I have GVs, so if we had a cycle where we had 6 M2s and 3 GVs, I'm going to look at how big the follicles were. And the ones that were GV need to get bigger. We usually say that the average diameter for a follicle to be mature is going to be about 15 to 20 millimeters. Some women will have mature eggs at 13, some will have mature eggs at 24. Everybody's different. Once we've gone through a cycle, we know better what's mature for you. So do they need to be pushed a little bit bigger if they weren't in that size range? On the other end, if you didn't retrieve as many as you were hoping, was something pushed too big? Did it degenerate so there was no egg to get? Or was it so small that it couldn't even enter that meiosis stage and maybe wasn't retrieved? Maybe you had too much of what we call a dichotomous cohort. They weren't synchronized enough. And that is something that I look at switching the protocol. So maybe the suppression that we let in with, can we do it longer or shorter or switch it up to try to get a more synchronized group of eggs growing? So those are all questions that I'm asking when we're thinking through, did the protocol do its job of trying to get as many mature eggs as possible? Importantly, not every mature egg is going to be fertilized, is going to grow to an implantation stage embryo called a blastocyst, is going to be genetically normal, and is going to become a baby. And that is really important when you're having to talk with your doctor about how many cycles do I need to do. If we say you have 20 mature eggs, okay, Not every egg that's frozen survives the freeze thaw. We usually say about 90% will survive the freeze thaw, which is so much better than 10 years ago when it was closer to 40%. But that means we are going to take a loss if we freeze things as eggs. It's not a huge loss, but it needs to be accounted for when you're deciding if you've frozen enough eggs. So if I have 20 eggs frozen and now I go to thaw them and I have 18, average fertilization is going to be around 75%. Let's say 14 have now fertilized. About half of these will usually grow through to make a blastocyst, so now I have 7. The rate of genetically normal is going to depend on your age. So if you're 35, it's going to be half. If you're 38, it's going to be a third. If you're 40, it's going to be closer to 20 to 25%. So you can see that you're going to have less of those euploid or genetically normal based on how old you are. And the worst part about egg freezing is that we don't know the answer until we're already too late down the road, meaning I don't know how many are usable embryos until I go to fertilize them, and that's not now because I'm freezing my eggs. So having more eggs is how you buffer that risk, diversify your assets. The other thing to understand is that not even a genetically normal embryo is going to give you a baby 100% of the time. One genetically normal embryo has about a 65% chance of live birth. So if we use the analogy I just said, and we had 7 embryos to send off for genetic testing, we're 35. Now we say, okay, let's have 3 of them that are euploid. Well, one embryo has a 65% chance. After transferring 2, it's in the mid-80s. After transferring 3, it's a 95% chance of a live birth. So IVF is relatively effective, asterisk, if you have enough embryos. So we want to see 2 to 3 genetically normal embryos for every child that you might want to have in the future. And this was starting with 20 eggs. So we probably need to consider doing more than one additional cycle if we only have 6 mature eggs right now. The other thing to say is that M1s are often frozen and kept, but they have to mature in the dish before they can be fertilized. So they have potential, but much less than M2s. So when I'm trying to make decisions about how many eggs we need, I'm always counseling my patients based on the M2s that we have. Those M1s are considered bonus. If they mature and they can fertilize, yay, but I'm not banking on them for my future fertility. Hope that helps. Wishing you all the best. I understand trying to freeze your eggs and have a demanding career can be really tough, but you're doing the best thing you can for your future by putting eggs in the freezer and keeping that door of opportunity open. All right, we're going to hear from another listener. And a reminder, if you would like to call and leave your question, 657-229-3672.
Hi, Dr. Crawford. Thank you for everything that you do. I've learned so much from you. I have had 4 egg retrievals with the goal of making embryos, and out of those 4 egg retrievals, we've been able to get 4 blastocysts. Unfortunately, all 4 of them have had chromosome abnormalities when we did PGT testing. I'm turning 40 this year, and my doctor continues to tell me it's just because of advanced maternal age and luck of the draw, and that it's primarily the eggs that contribute to the chromosome abnormalities. When I asked him about further testing for my husband, things like sperm DNA fragmentation, sperm aneuploidy test, he kind of dismissed those and really said it's all because of my eggs. I'm curious if you would recommend further testing, or if we just keep trying and hope it is just luck of the draw. Thank you.
I really hate when we feel dismissed. You're trying to advocate for yourself and ask really good questions, and then somebody doesn't even take them seriously. And it's not that your questions are bad. Sometimes it is that we're searching for something to do about them that may not always be the right thing, or may not fully give us the answer that we want. 2 things can also be true at the same time. Average means just that. Some people do better and some people do worse. And can you fall on the bad side of average over and over again? Absolutely. And I have patients who it happens to. Sucks a lot. However, anytime we're falling on the wrong side of average, I'm always stepping back and saying, why is this going on? Why do you have low ovarian reserve? Why do we have 0 out of 4 genetically normal instead of maybe we should have 1 based on our age? Now you can see how the low side of average doesn't make it as concerning. If I would expect 1 out of 4 to be normal at your age and we have 0 out of 4, that could just be bad luck. But it's important to step back and look at everything. Yes, egg-related aneuploidy or genetic abnormality is one of the top causes that stands in our way or causes embryos to be genetically abnormal. But it's definitely not the only thing, nor is there nothing that you can do about it. Sometimes talking to the lab and looking at some of our cycle parameters can be very helpful. Things like, did we get a good number of mature eggs? Did we have the right proportion fertilized? Did we have a normal amount make it to blastocyst? Those things all falling in line can be reassuring signs at different places. Meaning if you're doing ICSI and taking a sperm and putting it into an egg and you see low fertilization, that's actually really concerning on the egg because I'm not relying on the sperm to do something at that point. I'm actually relying on the egg. If I see a huge drop in my embryo development, half of them aren't going to make it. But if you had 20 that fertilized and then only 4 that made it to the blastocyst stage, why are so many dropping off? If a lot of this development is halting at day 3, which is the 6 to 8 cell stage, that's when the male genome kicks in, that can be a sign there might be some sperm genetic abnormality contributing. Not every lab looks at the embryos then, so that's something to consider, but that can be a clue. On the other hand, if you just lost some then, and then some made it past then, maybe to this morula, this almost blastocyst stage, then that's more of normal finding. But if you really saw, wow, everything dropped off right at this one day, that's concerning for sperm. And I've had that happen, had honest talks with my couples, seen that maybe there was a lot of marijuana use, or maybe we weren't sleeping, or we had really drinking a lot, had some factor that might be impacting the quality of our sperm, even if it looked good under the microscope. Checking sperm under a microscope is not a representation of its functionality. So the test, though, things like a DNA sperm fragmentation, doesn't always give us the answer that we want. This test was made to kind of look inside the sperm and decide how fragmented is the DNA or how damaged is it, which sounds really helpful in theory. The studies that have shown it to be helpful we're recommending that if you had a highly fragmented sperm that you consider doing ICSI, intracytoplasmic sperm injection, taking one sperm and putting it in an egg. So many of us do ICSI now, whether it's for unexplained infertility or for male factor or for age-related factors with the eggs. That has almost become a moot point because I bet you did ICSI. Now, if you didn't, there's a conversation to say, should we consider doing that? Could that improve fertilization? Should we do a DNA sperm frag to tell us should we or should we not? But doing that test, if it's not going to change what you're doing about it, always poses a question of, is that information helpful? Sometimes it is for my patients, and sometimes it's not. If there is room for movement in lifestyle, that should always happen first. Can we eat more whole foods, both of us, but especially the sperm? Stop marijuana, stop alcohol, stop nicotine. Can we get more sleep? Are we exposing our testes to more heat? Can we take some anti-inflammatory supplements? What can we do to try to improve the environment of the sperm development? And remember, the sperm life cycle takes about 3 months. I always think this is a good time for both of us to do this together, right? What's good for our eggs is good for our sperm, and none of this stuff is really shocking for most people. I also would think about, yes, we often see age-related aneuploidy as a limiting factor when somebody's 39, 40, and could just be bad luck. It could be poor quality eggs sometimes gets us into infertility and we have lower egg quality than we want. Is there something we can do? Is there room for movement on our lifestyle factors there? What about the protocol? Why is our egg quality worse? Could we have some endometriosis or something autoimmune? Should we shift up the protocol we're doing? Can a Lupron protocol grow our eggs in a different environment? Should we consider adding human growth hormone on? There's no one-size-fits-all answer, but this is what I'm thinking about in my brain when I'm seeing a patient who's not had the outcome that I want. Did everything fall average along the course of making embryos and we just had 1 out of 4 should have been normal and we had 0 out of 4, and I would say that might just be bad luck. It might just be, and we should do another cycle and hope that we're not falling into that. But if we're trying to take charge and do what we can, that would be looking at anti-inflammatory factors for both of us. So the foods we eat, supplements we can take, getting sleep, managing stress, exercising, avoiding toxins, and really how can we incorporate that to have hopefully a better cycle, in addition to cycle-specific parameters. What protocol did we do? Why are we in this position? Should we consider some add-ons that maybe could help or at least aren't going to hurt? Can we get more mature eggs? That's always going to help the equation. Did we do ICSI? Was there a big drop-off at some point, and when was that? Those are the questions that I'm always asking in a WTF visit when the cycle didn't go just the way we wanted to. And sometimes this is a visit with your doctor, sometimes it's a message, sometimes your doctor might need to talk to the lab and get some lab input, because sometimes the lab will say, hey, the sperm really wasn't moving well, or the eggs were really fragile, and when I went to go fertilize them, they didn't do great. And so sometimes we can get some information that is helpful from talking to the lab. So your doctor may not have it all right on hand, but it's at least worth doing the digging so that you can set into your next cycle as the best advocate, feeling confident about your plan. We can't control everything when it comes to IVF and egg freezing. That's part of the hardest, but we can control that we feel good with our plan, our questions are answered, we understand what we're doing, and that we're controlling all the factors that we can to set ourselves up with the best egg quality, sperm quality for success. Hopefully this helped answer some of your questions and thoughts that you might have if you're trying to improve your own cycle outcome. If you have questions, please feel free to call and leave them on the voicemail at 657-229-3672. Again, that is 657-229-3672. You can also ask questions on Instagram on Monday at nataliecrawfordmd and sign up for the weekly newsletter at nataliecrawfordmd.com/newsletter. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.